Good evening, everybody. Today is Tuesday, August 16th, 2022. We will be doing a case list defense webinar tonight. With a show of hands, can you just let me know that the audio is working appropriately this evening? Okay, perfect. Thank you. You can put those hands down. Thank you so much. Does anybody have any questions about anything before we start? About anything in general? Okay, I don't see any questions. Anybody want to be part of the hot seat? Okay. Shioma, I'm heading in your direction.
Hi, can you hear me okay?
Yeah, can you hear me?
Yes.
Awesome. And remind me, you're a generalist, correct?
Correct.
Okay. You submitted your case list?
Yes.
And you cannot see my screen, correct?
No, I cannot.
Okay, I've blacked it out here for a second. So
Okay.
we have two options. One option is there a specific case that you'd like to discuss, or we can do topic-based. And that's what I have noticed. That's what a lot of the recent candidates who have recently taken the exam, they either pick at your cases or they just use your list just to springboard with topics.
If you don't mind, I would like to do topic-based.
Okay. Now, what would you like to do? OB, office, GYN?
I'll try OB today.
We'll do OB?
Yes.
So no specific case you want to go over?
No.
Okay. So you're doing a delivery, the baby's head comes out, and you get a shoulder dystocia. Tell me how you handle shoulder dystocia in your practice.
Okay, sure. So I would first assess and have the nursing staff help me to position the patient in McRoberts. So essentially just pushing so typically the patient is already kind of in modified McRoberts, but then by flexing the hips a little bit further cephalad, that kind of assists with making room to be able to help with the fetal shoulder delivery under the pubic bone. And then I would also have another nurse assist by having a step stool and providing me with suprapubic pressure. Also, typically during the once I encounter a shoulder dystocia, we do announce that it is considered an OB emergency. So there is an alarm that we sound, and so we have a lot of staff in the room. I typically notify the patient and the family member and kind of let them know what's going on. So all of that assessment's kind of done quickly. The OB emergency button also triggers the NICU team to be aware, and then the charge nurse is usually getting the operating room available and open as well at that time. So we would start with the McRoberts and the suprapubic pressure, and then from there I would attempt to deliver the posterior arm if I'm able to. Also, anesthesiology is available as well typically, and so if the patient doesn't have epidural anesthesia, assessing to be able to improve her pain control while I'm attempting my maneuvers.
So what would anesthesia do in order to improve the pain control?
In this case, if the patient had an epidural, then they could administer, because the catheter is there, they can administer more medication to help with the patient's discomfort from my maneuvers.
Let's say she doesn't have an epidural.
If she does not, then if she has adequate IV access, we could try an IV narcotic medication to see if that will help. But
What narcotic medication?
Typically we would do fentanyl, which might help a little bit. We could also consider, because this is an emergency, I would not typically do a pudendal block, but that would also be a consideration as well for anesthesia. And then you can also give like nitrous as well And with the anesthesiologist there, they can monitor and administer that to help.
So you did your McRoberts, you did the suprapubic, you attempted to get the posterior shoulder, you're unsuccessful. What would you do?
Then I would attempt to rotate the fetus. So that would be the wood screw maneuver. And so then that is attempting to move the arm that's currently, or the shoulder that's currently lodged under the pubic bone. It can help rotate to see if we can free that shoulder, and typically it rotates the fetus, and then attempting to deliver with using the other shoulder being anterior, and then the previous shoulder then becomes posterior.
Let's say that doesn't work. What would you do?
Next, I would try the Rubin maneuver, and so that's kind of decreasing the anterior posterior diameter between the shoulders to help to see if that will facilitate delivery.
Doesn't work. What would you do next?
I would also cut a mediolateral episiotomy if I feel like I'm limited by room, which that can typically be the case.
Still no success. What would you do?
I would, at this point, I would assess, so I would also have somebody assessing how much time has elapsed. And if it's been less than, usually around like a minute and a half, is I would typically go through the sequence of maneuvers again, because that can sometimes help to facilitate the delivery.
Still no success. What would you do next?
At that point, I am moving towards the operating room.
And what would you do in the operating room?
In the operating room, I would attempt the maneuvers one more time. And if that's not successful, then I would try to replace the fetal head, so destation the fetus, and then proceed with abdominal rescue.
So how do you do that with the head? What did you say?
I would destation the head, essentially.
Destation. How would you do that?
So you essentially, like, I am not 100% sure on the technique, but I would think about the typical maneuvers for descent in the during labor, and so then you're essentially kind of doing the opposite of that sequence of maneuvers to try to so that the head is not as, I guess, caudad, I guess. So trying to deviate it cephalad to help facilitate your delivery with abdominal rescue. But I wouldn't spend much time doing that. I would just proceed with abdominal rescue, and you can attempt to deliver breech.
What is Erb's palsy?
Erb's palsy is a brachial plexus injury that can occur in the course of shoulder dystocia.
And where is the injury located?
Erb's palsy, I believe it has to do with the cervical nerve roots.
Can you tell me the specific nerve roots?
I am not 100% sure, but I would guess C5 through C6 are involved.
And how does the palsy present?
I am not 100% sure. I would think that the infant would have trouble with grasp, and then also the limb would be shorter than the other.
Why would it be shorter?
Because typically if this injury has been sustained during the neonatal period, then it impacts the growth, like the normal, growth process.
Okay, let's stop there. What do you think?
That was very difficult. I have not yet reviewed my maneuver, so being able to articulate it is very challenging, but I think it was a really good exercise, so thank you.
So herbs is the waiter's tip, and it's injury at C5 and C6, so you were correct. I don't know how much I would bring up anesthesia in regards to, like, how many, I'm assuming you've had shoulder dystocias in your life, correct?
Correct.
Were you that concerned about anesthesia? I'm
No.
talking about, yeah.
No.
So I would not bring that up because,
Okay.
I mean, you have minutes. You have minutes. She feels uncomfortable. I feel bad. The only time is if you cannot do your maneuvers, but if you can't do your maneuvers, you better start moving her to the back, right?
Yeah.
Because you're just going to be struggling. So you always, you start off with the simple stuff first, the McRoberts, your suprapubic pressure. And then if that doesn't work, you go towards your delivery of the posterior arm. You were correct, you do your wood screw. That doesn't work, you go the other way, the Rubens. Now, how about clavicular fracture? You didn't bring that up. That's an option, correct? Are you with me? Did I lose you?
Yes, I'm with you. Yes, I'm with you.
So clavicular fracture, and how would you do that?
You would apply pressure to the mid portion of the infant's clavicle, I'm guessing.
How would you put the pressure? In or out?
Outwards.
You snap it out, because if you press it in, it could damage the lung when you fracture the clavicle. So hopefully that'll break down that shoulder diameter. That doesn't work, then you go to the other side. And while all this is going on, you keep repeating your McRoberts, your suprapubic, the posterior shoulder delivery, because hopefully at some point it'll give. Does that make sense?
Yes, that makes sense. Thank you.
Okay, and you did the right medial lateral episiotomy. They could have asked you other questions about that. So something that people have brought up and some people swear by is something called the Gaskin maneuver. Do you know what that is?
I don't immediately recall. No.
Surely. So a Gaskin maneuver is you put the patient in all fours. It's a midwifery maneuver as you're moving her to the back, to the operating room. And instead of downward traction, you go upwards, right? Because the patient's backwards.
Okay.
And some people swear that that will help, that the shoulder will dislodge at that point. You're going to the back, you might as well use that time wisely. You literally have to be on the bed with her, and of course everybody's going to be seeing her rear end as she's moving down the hallway. So some people swear by it. So then you get her in the operating room. A Zavanelli maneuver is very difficult to perform. It's very easy to say, oh, I'll do all my stuff backwards, but it's very hard to put that head back in. So you could definitely start doing that abdominal rescue, and then hopefully you can dislodge the shoulder from the top if you can't push that baby back in. Am I making sense? Or deliver it as a breech.
Yes, yes.
Also, when I took the exam years ago, we were never supposed to say symphysiotomy. Apparently, it's more accepted now. I don't know what changed. I'm not an MFM. But when I took the exam, if you were in an industrialized nation, that was not an option. It would be an option in a place where you did not have access to healthcare, in a third world country or whatever, as an example. So apparently symphysiotomy apparently is more accepted. It's it's as bad as doing a salmonelli, let's put it that way. When I took the exam, the salmonelli was better than the symphysiotomy. You were never supposed to say it, but apparently it's more accepted now. And in essence, you would have to like put a catheter in, move the urethra, and cut up. Because if you cut down, you'll cut through the bladder, urethra, and all that stuff. Does that make sense?
Yeah, so in terms of order, I guess you would do that prior to proceeding with the abdominal rescue?
I would do,
Or,
I mean, I'm going to be honest, because when I took the exam, the abdominal rescue was the way to go. Not to
okay.
do the symphysiotomy. Again, I'm not an MFM, but like I said, when I took the exam, that was a big no-no. And apparently now, in the last several years, it's more accepted. Because I know a couple of years ago, I was like, you can't do symphysiotomy. They're like, oh, no, you can do it now. And it was this big discussion amongst everybody when we were doing the webinar that they were accepting of that. Of course, you do that, you better be well versed in how to do it, because they're gonna ding you for it. Let's put it that way. I think you're better off doing an abdominal rescue. Let's put it that way.
Okay.
And the question is, how long do you really have to deliver the baby before it's neurologically compromised? Some people say 5 minutes. So can you really do all this stuff in 5 minutes? And 5 minutes go by quick,
Right.
you know?
Yeah.
So questions? No, I think you did well. Just a couple of things. Don't forget the clavicular fracture and the gaskin that I can think of. And remember, while you're doing all that, keep doing your maneuvers. Keep going back to the basics. See if you can deliver that posterior shoulder now and stuff like that. Especially
Okay.
after the clavicular fracture, because you're decreasing that diameter.
Thank you. I have a question. I kind of struggled with I guess I could have just said Zavanelli. I was trying to describe it, and I think that that's what's going to be challenging with the oral exam, kind of like talking out what you would do and in very
I mean,
clear.
it would be very hard. I mean, I've never done it. I had a friend who did it. Said it was very, very hard.
Okay.
It's not as easy as everybody thinks. And another thing, look, again, I've never done it, but it makes you think, will you have to give a uterine relaxant in order to push that baby back up again?
Right. Right. Okay.
You know what I'm saying? So would it be better to do an abdominal rescue and kind of help from the top? Luckily, I've never been in that type of situation, but at that point, I mean, all heck is breaking loose at that point, so to speak, you know?
Exactly.
I have a question here. Somebody typed in the box, so let's take a look here. Give me a second. Is there a side that is better to do clavicular fracture, left versus right? This is from Daniel. To my understanding, no. Whichever one you can get to easiest. And if that doesn't work, then you go to the other side. The key is you snap up. You don't snap in, because then you can cause lung injury to the baby. Okay? Okay. Chioma, question. Another thing, you said we. It's all I. I did this, I did that. I know it's very hard to do that. But it should be not we, but I.
Okay.
Okay?
Thank you so much.
Okay, no worries, but good job, good job. Okay? Anybody else want to be part of the hot seat? I got Matthew, I'm coming in your direction. Says you're self-muted. You there, Matthew?
Hi there. Yes.
Hey, how you doing? How's it going?
Good. How are you?
Good, good, good. Are you a generalist or a subspecialist?
Generalist.
All righty. Do you want to go over a case in your list? Do you want a topic? What do you want to do?
If we could do a topic, maybe in GYN, let's do that.
GYN, all right. I'm here thinking.
No, that's okay.
Sometimes easier said than done, right?
I mean,
So discuss for me how, yeah, go ahead.
I was just gonna say you can also use my list and just randomly pick up one too. But
No, no worries. Discuss for me how you enter the abdomen for your laparoscopic cases and why.
So the patient is in dorsal lithotomy position after being prepped, and surgical timeout is performed to confirm the procedure in the patient. Then it depends on a patient's past surgical history typically, and what the surgery is, the indication for the surgery. But
why is that a factor?
Sorry, the indication or the past surgical history, or both?
For both.
Oh,
You explain each one the
Sure.
same, separate? Yeah.
Sure. So if a patient has a past surgical history that includes large abdominal incision or multiple laparoscopic incisions, there's a concern for adhesive disease, especially with bowel adhesion to the anterior abdominal wall. So typically, I would say the majority of laparoscopic surgeries include an umbilical incision of some sort, which is typically where I would enter the abdomen. However, if I had a concern for bowel adhesions or adhesive disease at that desired site, I would then choose Palmer's point in the left upper quadrant after placing.
So what is Palmer's point? Can you tell me exactly where it's at?
Sure, it's in the mid-clavicular line, approximately 2 to 3 finger breadths inferior to the subcostal margin. Yeah.
So let's say the patient's had no surgery.
So if the patient has had no surgery, I typically enter with I make a 5mm infraumbilical incision, and elevate the anterior abdominal wall by providing traction on the patient's abdomen, and use a Verus needle to enter. I then use a saline syringe with drawback, and then
And why do you do that?
I use the drawback in order to determine if there's any fluids, blood, or other substances that may come up, to indicate that I've entered something that I don't want to enter, like a hollow.
So let's say you draw back blood. What would you do?
I would then have significant concern for vascular injury, at which point I would it would take time to enter with a laparoscope and insulate the abdomen at that point. If there is blood, I might convert to open at that point.
And what would you do with the Verus?
Leave it in place.
Regardless, let's say you got stool out.
If stool were the case, then it wouldn't be necessarily as much of an issue given the diameter of the Verus needle. So I would insulate the abdomen at that point, and evaluate for a bowel injury.
So you would take out the Verus? If you had bowel injury?
Typically, I'm trying to think. No, in order to locate the injury, I would typically leave it in place and enter at another site, so that I could locate the injury more easily.
I mean, because if you took out the Verus, do you think it'd be easy to find the injury?
No, it's a pinpoint.
You're that great at running the bowel?
No, yeah, it's a pinpoint injury. So
So
no,
what would you do?
I would leave it in place and then enter in a different location, insufflate, and still proceed with a diagnostic laparoscopy to evaluate the injury.
So let's say you get a bowel injury.
Mm-hmm.
How would you repair that?
I would use a permanent suture, like a 2O silk, on a small needle, typically an SH, and repair it. The incision, excuse me, the suture line would be perpendicular to the direction of the lumen, but the throws would be parallel to the direction of the lumen.
And you would use silk,
Yes.
even if it's a full through and through?
If it's a full through and through, I would likely contact general surgery to evaluate that, as I do not have expertise to repair a through and through.
So you would use non-absorbable suture on your bowel?
Yes.
Sure about that?
That's what I saw my gyno using when I was training, so yeah.
Throughout the entire repair of the bowel, or only a certain aspect of it?
Only a certain aspect of it. If it was a small damage to serosa or to the muscularis, he would typically use a 2O silk.
So let's say the entire bowel, the entire thickness of the bowel is injured. You would still use the silk, or you use something else?
Typically, I believe a Vicryl would be used at that point if it was a full thickness injury.
Now, at what point with an injury would you do a resection of the bowel?
If there was a thermal injury to the bowel, that would require resection. Or if the injury to the bowel is greater than, I believe it is 0.5 centimeters. But I would have to double check.
So
that last
5
part.
millimeter, a 5 millimeter laceration, you would resect the bowel?
I would have to double check the actual length of the injury, which would require resection.
And you said, so in what direction would you do the repair?
The suture line would be perpendicular to the lumen of the bowel. However, the individual throws of the suture would be parallel to the lumen of the bowel.
And why do you do that?
To avoid a leading edge or leading point, so that it would not cause obstruction or intussusception.
I said obstruction and what?
Intussusception.
Okay. Let's go back to the laparoscopy.
Okay.
So you go in with the varus.
Mm-hmm.
It goes in smoothly. There's no injury.
Mm-hmm.
What would you do next? So you got the varus in. What would you do next?
While maintaining traction on the anterior abdominal wall, then we would connect the CO2 insufflation, making sure that the opening abdominal pressure is less than 10 millimeters mercury, and insufflate to 15 millimeters mercury. I then use a OptiView trocar, non-bladed trocar with my 5 millimeter scope to enter the abdomen and peritoneal cavity. I do my full abdominal survey, including the upper and lower abdomen, and then I place the patient in Trendelenburg birth positioning to access the pelvis. I then place my right and left lower quadrant ports under direct visualization, typically 5 millimeter ports, and commence with my laparoscopy.
All right, we're stopped there. Very good. What'd you think?
I
You
wasn't
didn't
sure
think
if
I was gonna go in that direction, huh?
I had a feeling when it wasn't specific that it might have gone in that direction.
And they do that all the
especially
time,
with, yeah,
unfortunately, all the time.
and
When
I
you least
guess
expect it, they give you the zingers.
and that's why I was not ready for some of the answers. I think my main concern was I wasn't sure if if I spoke too much with regard to like the injuries that require certain types of repair. Like, could I have just stopped at like thermal injury, and then they could have been like, what if you have a trocar injury to the bowel or something like that? That's where, because I didn't know the answer beforehand.
Yeah, that's a tough one. You don't know, but also if you wanted to lead them to a certain direction, you could say thermal injury and hopefully they'll ask you questions there. But if you stop, then they could pick any injury they want. You see what I'm saying?
Right.
So that's a tough one. And of course, when it comes to injuries, we don't feel comfortable with any of them, do we? Right? No, we don't.
Correct.
Do we have a GYN oncologist on the call? Do you mind like putting a question in the question box saying, hey? Of course, when you need an oncologist, they're nowhere to be found. Nobody's typing. So to my understanding,
I know
go
it
ahead.
was, I believe from what I read, and this was several years ago in residency, I think it's 0.5 centimeters or less.
It depends who you talk to, but I think the max would be 2 centimeters. Anything less than 2 centimeters, you could do a primary repair.
Right, okay.
Right. The problem with thermal injury is you may not be able to identify it. That's going to be a problem.
Yeah.
That's your problem with thermal injury.
Mhm.
And that's why they present so much later. So, Aaron, are you a GYN oncologist? Because you wrote hi. I don't know, he's not responding. So, to my understanding, if you have an injury, you went through bowel, definitely if you went through a vascular, leave everything in place. Because it's, if you pull out if you went through a vessel, you're gonna make that person bleed like crazy, right?
Mm-hmm.
And then in regards to the bowel, you won't be able to find the injury, correct?
Correct.
And you could have a full through and through. You could have put the varus right through, not the top part of the bowel, but the bottom as well. You see what I'm saying? So you leave everything as is. Great idea. Go to Palmer's Point so you can see where you're at. You may want to call an assist general surgery, oncology, because you just want to make sure that it's properly evaluated and properly repaired if needed. Correct?
Okay, sure, yeah.
So if it's less than 2 centimeters, you could do primary repair. Greater than 2 centimeters, you should consider resection. Of course, all general surgeons and oncologists do different things, right?
Mm-hmm.
So you want to repair, if it's parallel to the long axis of the bowel, you close end to end to avoid narrowing of the lumen. That's the key, okay? The mucosa muscularis in a single layer with interrupted 3O, and muscularis serosa with 3O non-absorbable. That's where your soak comes in.
Sorry, could you say that again?
So you do the mucosa muscularis in a single layer with interrupted 3O.
Okay.
And then muscularis serosa with 3O non-absorbable suture. That's the silk. Now, how many general surgeons do I see use silk on the bowel? I haven't seen that in years.
Okay.
The old docs, yeah. And if your laceration is at a right angle to the long axis of the bowel, you close side to side. So the bowel closure is always orienting the line of laceration perpendicular to the long axis of the bowel. Again, to avoid that narrowing of the lumen.
Is the way I said it, does that make sense? Like
for me, I sometimes have to sit and think about it. Remember, you're gonna have a pad of paper in front of you. Draw it.
Okay.
If you feel you're struggling, just draw it. That's easy breezy right there.
Okay.
You were correct with your Palmer's Point. So very good there. And I thought the way you presented what you would do, with the varus and then you do the OptiView and all that. That was very nice.
Okay.
Other questions? Anything else we left pending? But something very simple, we can make it very difficult, right?
Sure.
And they do that, unfortunately.
Okay.
Again,
you.
is there an oncologist on the line? Just seeing if I'm correct in what I'm saying. And of course, I've seen oncologists and general surgery do things differently, but this is what the book says, for lack of a better word.
Okay.
Okay.
Thank you.
Any other questions? Good job.
Thanks.
All righty. It won't let me unmute a fellowship, but Aaron says he's doing some research, but let's see if he has anything to add here. Let me see. Are you there, Aaron?
Oh, there we go. I
There
don't know
you
why.
go. Do you want to add anything? Did I say anything out of turn?
No, and I'm only in my research year of fellowship, so can't offer much more. But
Oh, okay. So your first year is research.
uh-huh.
Oh, okay. All right. Cool. All right. Well, thank you. Appreciate it.
I did have one last question, if I
Go
could.
ahead.
Was I right in thinking that if I had a vascular injury, I would go straight to laparotomy, or would I? It's just a tricky.
I
large
actually, a lot of
vascular
vascular surgeons, they open them up. The
Yeah.
key here is not to take it out.
Okay.
I mean, if you got blood coming out, you hit something you shouldn't have.
Yeah.
Getting everybody on deck, so to speak.
Okay. I just wasn't sure, like, if a small vessel would be very hard to hit, so the likelihood of hitting a large vessel entering around the bifurcation of the iliacs or a common iliac is higher. So I just wasn't sure if
For
I
sure.
would go straight to laparotomy or.
I mean, I'd be calling for help for sure,
Okay.
And of course, you could see if the patient's decompensating and stuff like that, then all bets are off. You got to open her up immediately,
Mhm.
And it's the
Sure.
same thing with a hysteroscopy. If you've perfed and you have, an instrument that's heated or has a pointed edge, you leave it in, right? And then you do your laparoscopy so you can find where that injury's at. Once you pull it out, how are you going to find it? You can
Okay.
see where it happened on the uterus, but not beyond that, right? You don't know what hit on the other side.
Sure.
Yeah. I mean, you'll know if it's something bad because I'm assuming the patient might start decompensating. Definitely if you pulled out the varus. At that point, you leave everything in, and then you have to evaluate where that injury's at.
Okay. Thank you.
I mean, I'm not a vascular surgeon, but I would suspect a lot of these vascular surgeons, they do open patients up, to my understanding.
Yeah.
But I'm not an expert when it comes to that. Okay, other questions? Good job.
Thanks.
All righty. Okay, anybody else want to be part of the hot seat? Charlotte, I'm heading in your direction. Are you there?
Hi. Mm-hmm.
Hi, how you doing?
Good.
You're a generalist, correct?
Yes.
All right. Do you want a specific case? Or
Yeah, I was wondering if we could go over kind of a funky case on my GYN
Okay.
list.
Go look for it. Hold on. Let's take a look. GYN, you said?
Mm-hmm.
Which number?
15.
It's in the neoplasia column
Mm-hmm.
or category? Okay. Hold on. You can see the screen, right?
Now I can, yeah. Mm-hmm.
Okay. So present the case.
So this is a case of a 33-year-old G0 who had bulk symptoms and was found on ultrasound that she had at an outside institution to have what appeared to be a 12-centimeter fibroid. When she presented to me, I then ordered a pelvic MRI to better delineate the fibroid and plan for a laparoscopic myomectomy for her. On the MRI, it appeared that the fibroid was arising from the right fundus, and it was described as consistent with a fibroid in appearance. So I was doing this case with a partner. We started with a diagnostic laparoscopy and found that this mass did not look like a typical fibroid. It had blood vessels between the mass and the bowel, and then multiple adhesions connecting the mass to the pelvic sidewall. And so I was concerned that this could be a malignancy and considered biopsying the mass in the case, but was concerned about risk of seeding the abdomen if it were malignant. So we aborted the case and then referred her to GYN oncology, who ultimately resected the mass and found it to be a fibroid that had some atypical characteristics on pathology.
What do you mean by atypical characteristics?
No, I guess I need to read more about the hyalinized appearance and the hydropic degeneration, but I think it was benign, but there were some particular changes from
So
this.
do you know what a stump? You know what stump is?
I think that's a smooth muscle tumor of undetermined malignant potential.
So were you suspecting something like that?
Yeah, I was concerned that it could be, yes, a smooth muscle tumor that could have some features similar to a fibroid, but.
So what makes the classification malignant?
So on a histologic level, if there's invasion of beyond the basement membrane.
Anything else?
There are also features like predominance.
So you said that she had atypical cells. You said she had something that was atypical.
So the growth appearance of the fibroid and then some of the findings on the pathology were not standard.
So how much atypia does she have?
I don't know what the threshold is to be considered.
Do you know what she had? Because you said she had atypia, but it wasn't malignant. Am I correct?
I was using that term, I think not in the specific pathologic designation. So
do you know what the classic triad for carcinosarcoma is?
I think one of the features would be increased ratio between the nucleus and the cytoplasm, but I don't know more than that.
Okay, so let's say you wanted to resect this mass, and it's on the pelvic sidewall.
Mm-hmm.
Okay, can you describe for me the pathway of the ureter?
So the ureter originates from the kidney. It is about 50% of its length in the abdomen and the other 50% in the pelvis. It enters the pelvis at the pelvic rim at the location of the bifurcation of the iliac vessels, and then it courses on the medial aspect of the broad ligament, crosses under the uterine artery, and is about 1 to 2 centimeters lateral to the uterine arteries at the level of the cervix, and then enters the bladder.
And can you tell me predominantly at what point in hysterectomy can the ureter be injured? Mind you, you could have an injury anywhere.
Mm-hmm. Yeah,
And
there
in
are
terms of
four.
hysterectomy, but what are the major places you should be more cautious, for lack of a better
Mm-hmm.
word?
So main points of potential injury would be at the location of the IP ligaments, at the location of the uterine arteries, close to the uterosacral ligaments when ligating the uterosacrals, and then when closing the cuff, there can be injury to the ureters overlying the bladder.
Anywhere else?
I think those four locations that I mentioned would be the main risk sites.
So let's say you have an injury to the ureter. Let's say you have an injury at the IP.
Okay.
How would you repair that?
So it depends what the method of injury was. So if it were a thermal injury, then I'd have to consider resecting part of the ureter. If it's a sharp injury, then it could be repaired like end to end.
So you do an end-to-end repair?
Yes.
So how do you do that?
So I would place a stent to maintain the patency of the lumen, and I would use dissolvable sutures.
What else would you do?
So post-operatively, I would have the patient have a Foley in place to prevent any reflux and strain on the surgical site. And then I would do I would monitor her creatinine post-operatively as well, looking for any.
Why would you do that?
Well, now that I've said that, I've thought that if there's only one ureter that's obstructed, it shouldn't affect the creatinine. So I take that back.
So let's say you have an injury at the level of the uterosacral. How would you repair that?
I know there are different guidelines depending on where the ureter is transected as to whether you would implant the ureter onto the intact ureter or directly onto the bladder, but I don't recall those guidelines.
All right, let's stop here. What'd you think?
I mean, I think I need to do research on what the pathology descriptions mean for my particular case, and then yeah. So I got myself into a hole, and then I haven't reviewed yet about ureter injury and repair, but I know, yeah, that's definitely a topic that I need to review.
And you did the washings immediately when you saw the appearance of the myoma, the fibroid?
Yeah.
It's interesting the MRI didn't notice any of that.
Yeah, it was interesting. It was definitely an unexpected finding surgically.
You thought it was going to be an easy case. Pedunculate it, snip it, you're done.
Right.
Surprise, surprise, right? So at what point in a hysterectomy can the ureter be injured? At the IP, the uterine arteries, the uterosacral ligaments, the cuff angles. Okay. A stump. It's uterine smooth muscle tumor of uncertain potential that have some characteristics of sarcomas but do not meet full diagnostic criteria. It's classified malignant, abundant mitosis greater than 10/10 high power field. Prominent nuclear atypia, areas of coagulation, cell necrosis. The classic triad of carcinosarcoma is pain, bleeding, and rapid enlarging uterus. Carcinosarcoma is biphasic and characterized by both carcinomatous epithelial and sarcomatous connective tissue elements. It's based on the sarcomatous elements. I am not an oncologist, so that's just Greek to me. The course of the ureter. The ureter runs along the anterior surface of the psoas muscle to the pelvic brim. The ureter enters the pelvis at the bifurcation of the common iliac artery. It descends retroperitoneally on the lateral pelvic wall and runs posterior to the ovary. As it descends through the pelvis, its course becomes more medial. It is identified on the medial leaf of the broad ligament. It passes under the uterine artery or water under the bridge, and into the paracervical tissue, into the tunnel of the cardinal ligament or anterior bladder pillar, or the tunnel of Wortham. The ureter is located 1 to 2 centimeters lateral to the cervix and uterosacral ligaments. It courses immediately over the anterior vaginal fornix to enter the trigone in the posterior aspect of the bladder. So if you have an injury above the pelvic brim, you'd perform a ureterostomy, and you do that because you cannot mobilize the bladder. You spatulate the ends of the ureter. You place 4 to 6 interrupted sutures of fluorochromic through the full thickness of the cut edge. The site of the anastomosis is drained, and you can perform this regardless of the location of the injury, provided there is no tension on the repair. You put ureter extents and bladder catheter in situ for 10 days. If you have a breach that's less than 5 centimeters from the bladder, you do a ureteroneocystotomy. So you implant the ureter into the bladder. If the breach is more than 5 centimeters from the bladder, you do the ureteroneocystotomy, but you also perform a psoas itch in order to prevent tension on the repair. Because it's more, if it's 5 centimeters from the bladder, you're going to have tension on the repair. Does that make sense?
Yeah.
Questions? Did I miss anything?
No, I think you addressed everything. Thanks.
Okay, let me see if anybody has any questions. So they're saying, would it be ever be acceptable to say you are not credentialed to perform a certain procedure? You could definitely say, I personally do not feel comfortable doing this. I would get my, urogynecologist, urologist to come assist me. However, to my understanding, this is how it's done. They want you to know the theory behind it. Even though you personally may not do that repair, they want you to know the theory or the basics of it. Does that answer your question, Jessica? The histological findings of the carcinosarcoma. Sure, give me a second. So it's biphasic and characterized by both carcinomatous epithelial and sarcomatous connective tissue elements. Based on the sarcomatous elements, carcinosarcoma is often described as homologous if the sarcomatous element is native to the uterine tissue, or heterozygous if not native to the uterine tissue. So hopefully that answers your question. Okay. Any other questions? Okay. You're good there, Charlotte? Anything else?
Yep, I'm good.
Anything else about the case in general?
Not for me.
Okay. Because I mean, they could take you down to ureteral injury for sure, because it's in the pelvic sidewall, you know?
Yeah.
Bowel injury, but we already had discussed bowel injury, so. Any other questions? Okay. Anybody else want to be on the hot seat? We have a couple of minutes left. I'm here trying to unmute somebody, but I'm having some difficulty. I'm trying to mute Melissa. Are you there, Melissa? Says you're self-muted. Are you there?
Yes, I'm here. Yep.
How are you doing?
Hey, good. How are you?
Very good, very good. Do you have a specific case in mind or you want a topic? It's up to you.
I'll roll the dice with your topics.
Yeah? Well, seeing that we haven't done office, is it okay if we do office?
Oh, yeah.
Well, you sound excited. So how do you diagnose PCOS?
I typically diagnose using the Rotterdam criteria involving like 2 of 3 criteria involving usually a pattern of oligomenorrhea, signs of hirsutism, or findings on ultrasound such as like greater than 12 immature follicles per ovary, or increased ovarian volume.
How increased?
I believe that the number is like greater than 10 mLs per ovary. And for that criteria, you'd want 2 of those 3 things to be present.
So you said hirsutism. The patient has to have increased hair growth? There's no other way to evaluate that?
That can also be diagnosed with like a sign on the back of the neck, like acanthosis nigricans would also be a sign as well.
But you can't have somebody have PCOS and not be hirsute?
You can have PCOS and not have hirsutism, correct?
Okay. So you have a patient who has PCOS. What do you tell the patient? How do you counsel her?
So I counsel her on a few different aspects that in which PCOS may be of a future effect for her. One would be in regards to future pregnancies, and that there is the possibility, but not the definite possibility of chance of difficulties becoming pregnant in the future. As far as they would also have like an increased chance of like a metabolic syndrome development, or like in a pre-diabetic state.
So what's metabolic syndrome? How's that diagnosed?
So there's 5 aspects with metabolic syndrome that has to do with so blood pressure greater than 130/85, a waist circumference of greater than 35 inches, a low HDL, which I believe is less than 50. Triglycerides greater than 150. And I'm missing a fifth one. There is a fifth criteria as well, but that's I know 4 of the 5 of them off the top of my head.
And then, and how many of the criteria have to be present to meet the definition of metabolic syndrome? I didn't lose you, did I?
I'd have to review how many of them, but greater than 3 of those.
Okay. So your patient has a PCOS. So how do you counsel her?
Yeah, so in addition to pregnancy as well as metabolic concerns, there would also be the concern for potential for increased chance of endometrial and ovarian malignancies within her lifetime. So those would be the 3 aspects I would hit on. I would want to address with the patient as far as what her menstrual cycles are like. Is she currently, not having cycles like at least, every 3 months spontaneously? Is she on any sort of medication for menstrual regulation? I would also address her reproductive life plan as far as her plans for pregnancy in the near versus distant future, and determine from there as far as if she is not having a regular menstrual cycle, I would consider menstrual regulation for her. There would also be, if there is if she wants to discuss pregnancy options, and discusses issues with pregnancy, I may discuss with her the possibility of addition of metformin with the use of OCPs as far as to help with her cycles prior to attempting for pregnancy. If
So why
she
would you
was
start her on
interested,
why would you start her on metformin and OCPs? So
the
you're telling
combination
me
of
metformin's a treatment for
can help
PCOS?
with, sorry.
You're telling me metformin is a treatment for PCOS?
Well, it's helpful for a couple different things, as far as helpful for decreasing her insulin resistance, which is frequently increased in those with PCOS, as well as then.
So what's the mechanism of action of metformin?
So the technical term is called like a biguanide, I believe.
Yeah, so what does that mean?
What I believe what it's trying to do is, by acting that way, it helps us to increase our cells' sensitivity to insulin.
How does it do that?
Well, I know it increases our insulin sensitivity, but this is helpful for those who are either with some sort with increased insulin resistance. It is not helpful for somebody who would have like a type 1 diabetic kind of issue with their pancreas. But I know it's increasing our it has to work with the fact that our body is able to already make insulin.
Is there any contraindications to its use?
With metformin, Not that I can recall right now.
Okay. But if but you don't have to start the metformin, do you?
No.
And what about the OCPs?
So that's decreasing that's increasing the sex hormone binding globulin, and then decreasing our androgen production.
Is there anything else that the OCP does for a patient with PCOS?
Well, certainly can help as far as menstrual cycle regulation. It is likely as to, due to those effects as far as decreasing the androgen, it might have some positive effect as far as decreasing the hirsutism slightly.
So let's say the patient's not interested in starting either of them, and she's having periods every like 5 months. What would you instruct the patient?
If she's only having periods every 5 months, I would be concerned for her, and I would discuss with her my concerns for her lack of ovulatory cycles, her lack of ovulation that she's having, and also her likely buildup within her endometrium that could like possibly lead towards a higher risk of like endometrial hyperplasia in the future. And so for those patients, I would typically recommend, if they do not want to be placed on something for like monthly cycle regulation, I would recommend like a every 3-month course of short-term progestin treatment for 5 to 10 days in order to induce a withdrawal bleed.
Okay, let's stop there. What'd you think?
A very fair question.
All righty. Any questions before we go over it?
I'm sure I will come up with them as we just go over it.
Okay.
Yeah, go ahead.
Okay. Rotterdam criteria. You need 2 of the 3. Oligomenorrhea, hyperandrogenism, either through hirsutism or laboratory. You said she had to be hirsute. It could either be hirsute or the labs indicate one or the other. Okay.
Okay.
And polycystic appearance of the ovaries. You're correct. Don't say you said immature follicles, I think you said. It's greater than 12 cysts, 2 to 9 millimeters in size, or a greater than 10 cc volume to either ovary. That string of pearls that you could have that, but that's not something that's required. Metabolic syndrome, you forgot fasting of greater than 100.
Oh, okay.
But everything else was correct. It's a blood pressure of 130/85, waist circumference of greater than 35 inches, triglycerides of greater than 150, HDL of less than 50. You need 3 out of the 5. Mechanism of action of metformin, you're correct, is a biguanide, whatever that means. It decreases hepatic glucose production, decreases intestinal absorption of glucose, and increases insulin sensitivity. You're correct. It's not going to be very helpful for somebody that doesn't make any insulin, like a type 1 diabetic. You are correct. You get bonus points for that because you're doing that circulatory thinking. However, it could have backfired if you were wrong, right? But you were
Yes.
correct. So anything you say can backfire, right? Unless you're real versed on it. Contraindication, metformin use, impaired renal function, liver disease, alcohol abuse, history of lactic acidosis on metformin in the past. So metformin is not required. PCOS really doesn't have any treatment other than cycle regulation, weight loss, right?
Mm-hmm.
So always bring up your nutritional counseling. You even brought up if she wanted to get pregnant, you opened the door there. I wasn't going to go there, but you could have opened the door to ovulation induction. You feel confident with that topic?
Yes.
Oh, you do? Well, there you go. Then you open the door and hopefully they'll go in and you take them for a ride, so to speak. Because a lot of people don't feel very comfortable. You're a generalist, right?
Yes.
Okay. So let's say you were going to do ovulation induction. What would you do for this patient?
For PCOS, I would utilize Letrozole. It's given 5 days per cycle. I usually started on day 3.
Why letrozole?
In studies more recently with Letrozole versus clomid, it's had
So I
more.
can stop you there and say what studies?
Yeah. Oh,
Never say
don't. Oh,
studies, never say
wrong word.
literature.
Wrong word. Yes.
To my understanding, that's what you say. To my understanding. So continue.
Okay. To my understanding, there are there are higher rates of pregnancy with letrozole with PCOS patients, as well as slightly decreased percentages of multiples.
What's the mechanism of action of letrozole?
It's an aromatase inhibitor.
What does that mean?
So that it alters your conversion to
You're in the right direction.
I know, but I'm not able to word it right now.
Okay. Blocks conversion of androgen to estrogen.
Oh.
There you go. You're in the right direction. Just FYI, the increased rate or decreased rate of multiples, they've kind of proven in the literature now, don't say literature, that apparently it's almost the same as clomid. So that's not really one of the better. You have a better live birth rate if you have PCOS and a BMI greater than 30 with letrozole. It's
Okay.
20% with letrozole, 10% with clomid.
All right.
That's really the big one. So the risk of multiples is about the same for both. That's what the newer literature is saying, but again, don't say literature. Remember, who's testing you in your office? REI, very seasoned generalist. So the REI is going to know. I'm just a generalist. Other questions? Did we talk about everything I asked you about?
Was it decent that like I just touched on a couple different like lifestyle topics as far as why somebody should care that they have PCOS?
No, I thought that was very good. Lifestyle is important, weight loss and all that. The thing is, there's always this fear that you'll be saying too much. The only negative about saying too much is you can go down a rabbit hole if you say something you shouldn't say, like studies, right?
Right.
But I think it's better to find that happy medium instead of answering like very curtly, like, because then the examiner's like, man, they should know more than that. Does that? The key here is if they don't want to hear it, they're going to cut you off. And if you're on a good clip and you're answering it really well, they're going to cut you off because they know you know that topic. Let's go to something else. See if we can get you. Does that make sense?
Yeah.
So as long as you, and I think with practice, you will tailor and edit the words you use, right?
Like studies and pelvimetry.
Exactly. Yes, pelvimetry. Well, don't say that's like a bad word, man. That's a bad word. That's a bad word.
I said it a couple days ago, and right when I said it,
It's like, why did I say that?
Yeah.
And by practicing, you'll edit what you say. But again, if you're on a good clip, they're gonna cut you off because they know you know that topic. They want to go to something you don't know. And then of course you're going to remember the stuff you don't know. But then if you're doing that, that means you know more than you don't, and that's a positive, correct?
Yes.
You know, other questions? Yeah, but practice makes perfect for sure, especially in an oral exam.
I
You
don't
know,
think I
and
have
you know,
other
and the
questions.
people on the call, you know, it's a lot of the same people raising their hands. That's cool, man. But in the end, it behooves you to participate, because you could sit here and say, I never would have said that. That didn't make sense. But once you're in the hot seat, that pressure just changes your answers and how you think. Is it right, Melissa?
Yes.
Yeah, it's completely different. So you want to
I
get
like
accustomed.
rethought
Go ahead.
in my head what an aromatase inhibitor was.
There you go. And anything that's on any medication that you bring up, any medication on your list, you have to know the mechanism of action. As much as it pains you, you got to know it. So the only way you're going to get better is by practicing and, you know, being on the hot seat. I know it's uncomfortable and it's, you know, taped for prosperity and all that stuff. Sure, there's tapes of me saying gibberish years and years ago somewhere in the exam pro vault. But this is the only way I can sit here and say I passed, and that's what counts, right?
Yep.
So any other questions, Melissa?
No, thank you
Yeah, but
so
good
much.
job. Good job. Good job. All righty. So I'm going to lower everybody's hands. And does anybody have any questions? Because I know we're over time, but you know, we wanted to get into a good. I got a couple of hands up. I'm going to see if they have questions. I'm not quite sure. I'm going to Jessica. It says you're self-muted, Jessica. Oh, okay. The mechanism of action of metformin. Okay, give me a second. It increases the sensitivity to insulin, increases insulin sensitivity, decreases hepatic glucose production, decreases intestinal absorption of glucose. That answer your question, Eve Rose? Jessica, do you have a question? Okay, I think Jessica left the call. Can you go over if when we start metformin for PCOS again? Okay, Jessica doesn't have a question. Okay, cool. Metformin is not, like when I trained 20 years ago, you had to start people on metformin. They thought that was the treatment for PCOS, and they realized not that it's not it helps, but it's not a treatment. Okay, so you do not have to start metformin. That is not a requirement. Now, let's say the patient has like a hemoglobin A1C of you know, that's pre-diabetic. Would that patient benefit from metformin? Does that answer your question, Tiffany? But it's not a requirement. What's key for PCOS is to make sure that endometrial lining doesn't get thickened. Now, so you could fix that with OCPs, the progesterone, like Melissa had said. But let's say the patient's going to be interested in pregnancy at some point. So should you bring up the fact of, you know, healthy lifestyle, healthy eating, referral to a nutritionist? Because usually people with PCOS have that elevated BMI. So you want that better, you know, better health for better outcome for the pregnancy. Does that make sense? So some people would start that metformin because of the concern for that pre-diabetes if their hemoglobin A1C was kind of mildly elevated. Also, some people could lose weight on the metformin, but it does have the side effect of like diarrhea and stuff like that. So a lot of patients stop it. Does that answer your question, Tiffany? You know, it's not a requirement. So if you say you use metformin for treatment of PCOS, to my understanding, as of last year, that was not the case. It could assist in other things, but it's not a requirement. Okay, it was not a requirement. So please don't say I'm starting metformin to treat PCOS. That is not an indication. At this time, to my knowledge, I'm not an REI, but to my understanding that you'll start it for other things, but not specifically for that. Okay. Other questions? Just going down the line here. I'm going to lower everybody's hands if I can. Sometimes I can't. Chioma still has her hand up. I don't know if this is from the beginning. I'm just going to into her direction. She's self-muted. Okay, does anybody have any other questions? I just want to make sure before we end the call here. Just want to make sure I'm going through everything here. All right, I don't see anybody having any other questions. I'm just going to look down the line again. Anybody have any last minute questions or concerns? Okay, I don't see anybody. So at this point, I'm going to sign off. Everybody did really well. Thank you for participating. I know we went into some weird questions with like the ureteral injury and the bowel injury, but these are things you got to kind of know the theory of, not that you necessarily will do it in your surgical practice. But I think Chioma, Matthew, Charlotte, Melissa did a great job. So thank you for participating and being on the hot seat. Tomorrow you have a structured case webinar. So that's always a good webinar to join to see what questions can be brought up. But some of the stuff we brought up today could be brought up in a structured case. So in the end, as you participate in all these webinars, you get something out of it. Okay. So any questions before we sign off? I'm just going to look. I see nothing else. Hopefully this was beneficial. Any recommendations on doing something? Do you like doing the topics versus looking at somebody's list? If somebody writes something in the question box real quick, was that beneficial to do topics instead of looking at somebody's case list, unless you have a specific list case that you're concerned about, of course. Love the topics. All right, sweet. I like the topic, sweet. So that's something that we can do. Of course, if you have a case like I believe it was Charlotte, she had a concern with, you got to bring that up so we can kind of, but in the end, any case that can take you anywhere that you want. Let's put it that way. Anything is of fair game, so to speak. Aaron, what I'll try and do is pick you when I do my next webinar, because you were helped out with regards to the GYO or GYN oncology aspect, but I wasn't able to get to you because we were over time. But we'll get you on the flip side next week. Okay. So I really appreciate it, guys. Thank you for participating, and I wish you the best in your studies, and I wish you a good night. Thank you so much. Good night.